Welcome back to Therapeutic. Here we're going to talk about renal disease, both drug-induced renal disease. We'll talk a little bit about drugs that actually cause nephrotoxicity and some of the simplified mechanisms of those. And then we'll talk about adjunctive therapies used in patients with chronic renal disease, mostly for patients who are on dialysis. So as we think about the normal function of the kidney, there are multiple functions. Acid-base balance, it's a key player there. It has an endocrine function both in renin and erythropoietin production. It affects metabolism of a number of agents, including vitamin D activation, insulin and steroid metabolism, some enzyme function. We also see, and what we usually think of the kidney as the primary site for water and electrolyte balance, filtration, secretion, and reabsorption. And we also typically look at the rate of excretion as a function of the amount that's filtrated plus that's actively secreted into the lumen of the nephron, less the amount that's reabsorbed from the lumen of the nephron. So here's the functional unit of the kidney, the nephron, from top left moving along. We see the afferent and efferent and afferent arterioles in the glomerulus, where passive diffusion happens in the glomerulus into the lumen of the nephron. In the proximal tubule, we have a number of things moving back and forth across the tubules. Ultimately, we get down in the loop of Henle, where there is a difference in concentration gradient of sodium and therefore extraction of other substances and fluids as well. And finally, in the distal tubule, where we have a little bit more of the acid-base balance situation happening, ultimately to the collecting duct. So when patients have acute kidney injury, and often that's abbreviated as AKI, it could be related to drugs, it could be related to hypotensive events, it could be related to an infection, it could be related to a number of things. Typically, when we think of someone with acute kidney injury, most clinicians will consider a rise in serum creatinine of 0.5 milligrams per deciliter or greater as indicative of some acute kidney injury. But typically, for folks who already have chronic kidney disease, we expect those kind of fluctuations happening a lot. And so as such, we'd look for folks who have chronic kidney disease already that would look for a greater than 1 milligram per deciliter for acute on chronic kidney disease. We also look at the reduction in urine output, and many times this is the first thing you'll see, for example, in an ICU patient before creatinine rises. If they're going into acute kidney failure or acute kidney injury, you expect the urine output to drop. And so that's one marker we often will use carefully for patients to assess their kidney status. The Acute Kidney Injury Network also has diagnostic criteria in a 48-hour period that they have at least one of the following. Their guidelines are only a rise in serum creatinine of 0.3 milligrams per deciliter or 50% or greater increase in the baseline creatinine or the urine output falls, as we noted below, half a milliliter per kilogram per hour for more than 6 hours. Here are another set of ways that we stratify renal function or renal injury. And in a sense, some of these are some of the similar numbers we just spoke of. Some are a little bit different. And it depends on which guidelines or society you're looking at for how we quantify that. But for the most part, we look at patients who have a risk for renal dysfunction where it is a short-term change in their, a drop in their renal function. An injury to the kidney is when we see a larger drop in their GFR, usually by 50% or so. Failure of kidney function is when we see a threefold increase in serum creatinine or GFR that drops more than 75%, and urine output is almost negligible. Loss of kidney function, or also known as persistent acute kidney injury, is when the complete loss of kidney function is for a period of 4 weeks or greater, and end-stage kidney disease is for a period of 3 months or longer, and those individuals typically will require at some point dialysis. The risks for acute kidney injury, first of all, if they have pre-existing kidney injury, if their GFR is less than 60, they're at higher risk for further kidney injury. And those are the patients we're particularly careful about when we use drugs that are potentially nephrotoxic. Volume depletion is a big issue. We see this a lot in clinical practice if folks have become dehydrated because of vomiting, diarrhea, or other dehydration status, diuretics, or they have fever, they have volume shifts like ascites. And classically, we see in ascites the risk for hepatorenal failure, and that's a big concern. And also a lot of the nephrotoxic drugs, probably among the top on the list, are radiocontrast dyes that we use in imaging. And so those are notorious for causing acute kidney injury. Also, as we'll allude to in a bit, aminoglycosides, amphotericin, which thankfully we rarely use anymore. The nonsteroidals, which we use quite frequently, even the COX-2 inhibitors we'll talk more about in the pain management section, are kidney injury agents, as are in the short term ACE inhibitors and angiotensin receptor blockers. We'll talk a bit about the uniqueness of ACE inhibitors and ARBs because, in fact, they can be nephrotoxic, but they also are used long term to preserve renal function. And we'll talk about how they affect the head pressure and the glomerulus, and if it stays right where we want it, that's a great thing. If it doesn't stay where we want it, that's a problem. We also see some of the drugs we use in actually renal transplant are nephrotoxic, cyclosporin and tacrolimus. While they preserve renal function in a transplanted kidney by preserving the tissue, if the levels get too high, they can actually be nephrotoxic. Another risk factor for acute kidney injury is the obstruction, any obstruction in the urinary tract. Particularly, we think of a stone, but it could be somebody who has a mass that's pressing against the urethra or something like that. Here's a table that also lists some of the classifications of acute kidney injury that sort of mimic some of the things we just spoke about. But the factors we look at are of evaluating whether the patient is at risk for dysfunction, what their injury to the kidney is, the failure and for how much of that failure is the loss of their kidney function, and whether or not they're in ultimately end-stage renal disease. So these sort of mimic what we talked about, the milder at the top, and as we go down, more severe, more pronounced. So as we're looking at classifications of acute kidney injury as far as mechanisms go, we differentiate whether it's pre-renal, intrinsic, or what we sometimes call renal, or post-renal. Is the etiology or the mechanism involved related to volume depletion or affecting blood flow to the kidney? That would be pre-renal. In those cases, we might see drugs that also affect blood flow to the kidney. Those include the nonsteroidals, ACE inhibitors, or ARBs. And on physical examination, often the patient will have had a recent history of dehydration or hypotension. They might also have ascites, and so the mechanism of that hepatorenal syndrome we see, where they're centrally dry, means the kidney is dry, and that's the etiology. Typically, what you're going to see in a pre-renal state is a high BUN to creatinine ratio greater than 20 to 1. The urine sodium is typically going to be low, and we're going to calculate a fractional excretion of sodium. In the next slide, we have that formula. That's typically less than 1%. For intrinsic or acute tubular necrosis or acute interstitial nephritis, these are typically longer standing. They can be nephrotoxic agents, particularly contrast dye. Some of the antibiotics we typically see here. Most often we think of aminoglycoside antibiotics here. Could have a mechanism of vasculitis as well. There may be a rash or a fever, although that is not universal. The BUN to creatinine ratio is lower, about 15 to 1 typically, and the urine sodium is elevated. The fractional excretion of sodium is also higher, above 2%. Typically, there are also urine sediment, and maybe there are white cells and red cells and protein typically seen in the urine. Finally, post-renal is usually an obstruction. This is either a kidney stone or a BPH of an enlarged prostate in a man, or cancers with a mass, typically that would obstruct the urethra. The patient may have a distended bladder or an enlarged prostate on physical exam. And the findings, BUN to creatinine ratio and the fractional excretion of sodium, in a sense, mimic what we see with intrinsic acute renal injury as well. Here's the formula for the fractional excretion of sodium. We basically take the urine sodium divided by the serum sodium times 100 and divide that by the urine creatinine divided by the serum creatinine. And this gives us, in a sense, the percent of sodium that's excreted, and that is indicative of whether or not it is pre-renal versus intrinsic or post-renal. When we look at preventing acute kidney injury, our basic principles to prevent it in patients is, first of all, avoid those nephrotoxic drugs when we can, and making sure patients are adequately hydrated. Particularly true when we have drug-induced nephrotoxicity, the risk for that is much higher if the patient's dehydrated. We also look at acute situations where a patient could be dehydrated. For example, if they're sweating or if we're giving excessive diuretics for heart failure, we'd expect that centrally dry situation if we're aggressive with spironolactone and furosemide, for example, in a patient with ascites, so we're going to look at all of that. And there is a question about whether or not we should prophylax for preventing acute kidney injury in patients who get contrast dye. At the very least, there's at least universal acceptance for those patients when it's not medically contraindicated to really hydrate that patient with saline. Whether or not some of the other prophylaxis treatments we'll talk about in a bit for preventing contrast-induced, radiopathic contrast dye-induced nephropathy is a little bit more debated. When a patient already has acute kidney injury, we look at what our general approach is. Typically, if it's pre-renal, we correct the hemodynamics. So we often see folks who come in who are dehydrated with their bump up in their serum creatinine, and our first step is to hydrate them with normal saline to manage their blood pressures, and if they've lost blood, then maybe we need to give blood. When it's intrinsic, there is not a more universal approach, and typically, particularly with intrinsic renal failure, you're probably going to have a nephrologist involved. So once you calculate, you've estimated the BUN creatinine ratio, you look at their history, you look at what drugs they've been exposed to, whether or not they have AKI, and they're particularly going to pull a nephrologist in there. Typically, we're going to avoid further nephrotoxic drugs. We're going to do fluid electrolyte management. Maybe sometimes we'll see the use of a loop diuretic. Sometimes those are helpful. Some of the agents that have historically been tried, which are rarely used and really don't use, one is phenoldiazepam, which when that became available, a decade or so ago, people were excited as this being a real option for interstitial nephritis management. And it, for the most part, from when I speak to other clinicians, hasn't really borne out all that well, but might still be considered as a trial. And then historically, we used to use low-dose dopamine infusions, what we used to call renal dose dopamine, at a very low dose of under 5 mics per kilo per minute, which at least in theory would increase renal perfusion. But we don't do that anymore, partly because it has been no data that say it actually does any benefit at all. And then if it's post-renal, our situation is really do whatever we can to affect or to relieve the obstruction. So if it's a stone, for example, then we're going to look at doing whatever we can with lithotripsy or something to remove the stone. If it's a mass or if it's an enlarged prostate, then evaluating the degree to which we can manipulate that mass. Drug-induced kidney injury, and I'm going to spend a little time on this, is really something we try to avoid, and when it occurs, we look to correct it as soon as we identify it. So the risk factors for drug-induced kidney injury is a patient who already has predisposition to kidney injury. They have some early chronic kidney disease. Maybe their serum creatinine is below 60 or hovers around 60. Also, a higher age patient is a risk factor as well. The meds that are highest risk, amphotericin, we're going to really not talk about that because no one really uses amphotericin much anymore. Aminoglycosides, we don't use them nearly as much as we used to because nephrotoxicity is so common. Also, ototoxicity is pretty common with those, so we don't. The three, though, in the middle of this high-risk meds are pretty common. Non-steroidals, we use them a lot. ACE inhibitors and ARBs, we use them a lot. And contrast dyes, we also use them. So the kidney toxicity is in part because of kidney gets a lot of blood flow. There's a lot of autoregulation that affects blood flow through the glomerulus. Many of these drugs that are nephrotoxic have a high concentration in the kidney and or they're actually metabolized in the kidney, so there's an energy-dependent process there. They also might be involved in tubular transport. So we kind of see a lot of these factors that impact the risk for why certain drugs may be at predisposed risk for kidney injury. We also, though, have to differentiate real kidney injury from pseudo-nephrotoxicity. There aren't too many drugs really that fall into this category, but it's good to have them in the back of your mind. Triamterene, which is an ingredient in combination diuretic, it's the potassium-sparing component in Maxide or Diazide, or the older H2 blocker cimetidine actually can inhibit tubular secretion of creatinine, and that's not really indicative of any real change in glomerular filtration, so it doesn't really matter. We can have a number of drugs that might increase the blood urea nitrogen level without really affecting creatinine. We see this sometimes with tetracyclines or with the corticosteroids. And we have some drugs that interfere with the assay for creatinine itself in the lab, and these are usually the second generation cephalosporins, specifically cefoxitin. Let's look at this graphic and sort of break it down as we go along the flow of urine in the nephron and look at the different points that are susceptible to drug toxicity in the nephron. So first, and maybe the most important in most cases, particularly in pre-renal injury, is any drug that affects renal blood flow. So if we reduce renal blood flow, we're going to be at concern. So if we, for example, are excessively hypotensive, aggressive in our management of hypertension, and a patient has a hypotensive episode, or if they're in septic shock and have a hypotensive episode, or we give other drugs that affect renal blood flow, or they have renal artery stenosis, and we on top of that give an ACE or an ARB. All of those are really a mechanism for setting up for pre-renal acute kidney injury. We also see and we'll talk a bit about the specialized hemodynamics in glomerular filtration and maintaining head pressure in the glomerulus. So the ability to dilate or constrict the blood vessels just pre-glomerular and post-glomerular will affect the head pressure in the glomerulus, and that can make a big difference in renal function as well. And we'll come back and talk about that, but that is a big issue when we use ACE inhibitors or ARBs. We also can have issues with tubular luminar transport, epithelial, in the epithelial cells, drugs can accumulate. We also have drug metabolism happening in the cytochrome P450 systems, both in the proximal and the distal tubule. In the loop of Henle and also in the collecting duct, we have reabsorption happening, and that can be a situation that can result in higher concentrations of the nephrotoxic drug. We also have metabolic activity in the tubular cells going on, particularly in the distal tubule, and that change in energy requirement or energy release can all cause localized injury there as well. And finally, we have the acid-base situation in the distal tubule can result in precipitation of a drug, and that can cause the risk for an obstruction or crystal form. And so all of these are factors that are potential etiologies for how certain drugs can have or induce drug toxicity. Acute tubular necrosis, the interstitial situation, is probably one of the most common things that we'll see in an inpatient setting when we're using the drugs that are listed here. Thankfully, because we don't use aminoglycosides as much as we used to, and we rarely use amphotericin B, We see this less often than we did a decade or two ago. We do still use contrast dyes. There is a greater awareness, though, of looking at making sure patients are well hydrated before they get those contrast dyes, so that reduces that risk. And in oncology, we might see acute tubular necrosis with carboplatin and cisplatin, and almost universally with those agents in oncology suites when we're giving them, we first hydrate the patient, usually at least with a liter of saline and typically with mannitol and other things in it that will help get urine flow going and maintain adequate blood flow as well to the kidney to reduce those risks. So ATN still occurs, but we don't see it maybe as often as we used to a decade or two ago. The aminoglycoside acute tubular necrosis can happen in up to half of patients who are on aminoglycosides, which is why we don't like to use them. We often will see a gradual increase in their serum creatinine. We often are problematic for patients, this is particularly problematic for patients who are at already predisposed risk for injury, so we're careful about them. And the other issue with aminoglycosides is that to even use an aminoglycoside and then allow the aminoglycoside within a 24-hour period to really wash out of the tubules, we need somebody who has reasonable kidney function to start with. So if we're, for anybody who has a serum creatinine that's a bit elevated or a creatinine clearance less than 60 mils per minute, we're really hesitant about using aminoglycosides at all, really for two reasons. One is that they're going to predispose to this, but secondly, we can't actually get low enough levels to wash out of the tubules and reduce their risk for further kidney injury because their kidney function isn't that great to start with. So risk factors are typically when we have larger cumulative doses in folks who are predisposition to kidney toxicity and concurrent use of nephrotoxins. The way we'd prevent aminoglycoside toxicity is to avoid it in high-risk patients, make sure patients are hydrated, to try to limit how much and how long we give aminoglycosides for, and to use the longer interval dosing. But even still, our goal is to let most of the drug wash out of the tubules before we give another dose. But we can't wait so very long, like 72 hours typically. Sometimes we do. But the problem with that is that while in the last 24 hours of a 72-hour interval, you might be getting levels now nice and low and washed out and protecting the kidney, the post-antibiotic effect of the aminoglycoside is diminished, and so it's really not all that effective for that last day or so before the next dose is due. So aminoglycosides are troublesome to use for anyone who doesn't have good kidney function to start. Radiocontrast dyes, there are subsets of them. There are isoosmolar, low osmolar, and high osmolar agents. And there also can be characterized whether or not they're ionic or non-ionic. And there are multiple contrast dyes that are on the market. Typically, the imaging service will try to use the agent that is most appropriate, and if they can avoid using the contrast media and still get a good diagnostic result, that's often what is recommended. So you as a clinician may be working with the radiology team to determine the risk and the benefit of using a radiocontrast dye in the patient you have. The concern is that they are at high risk for patients who get radiocontrast dyes, at high risk for toxicity related to reactive oxygen species. It may cause renal ischemia, and many times we'll see in using these agents, we want to at least make sure that the patient is not hypotensive and is not dehydrated before we start. Typically, when somebody has radiocontrast acute tubular necrosis or ATN, typically it's going to start rising 2 or 3 days after the procedure, and about half of patients have oliguria. Some patients actually will require dialysis. Folks who are at risk of pre-existing renal disease, if they have diabetes, if they're volume depleted or older, if they have anemias, if they have anything that's related to poor blood flow to the kidney to start with, or hypotensive, if they have other nephrotoxins, if they get a large dose of the contrast, or if they're on hyperosmolar contrast agents. And so All of these are sort of variables we think of when we even decide to use contrast dye. In preventing radiocontrast ATN, probably the most effective and well-established protocol is to give saline and to give them a good amount of saline for a good 6 to 12 hours before the procedure to maintain a urine output of at least 150 mils per hour. There's some question about whether the addition of bicarbonate is helpful. It's conflicting data. It's possible, basically what you want to look at is weighing the risk and the benefit for the patient in front of you. Do they really need the contrast dye? More often, these days, we use the lower osmolar or isoosmolar contrast agents, which are less likely to induce a problem. Historically, their price was much more expensive. I think they're a little more competitive compared to standard therapies now. And then there are a couple of agents where there's conflicting evidence about whether they're given before or during and after contrast dye exposure. One is acetylcysteine, and the classic dose here was 600 milligrams twice a day for 48 hours, starting 24 hours before through 24 hours after the procedure. This was very commonly used, 4 or 5 years ago. In clinical practice, I think that a lot of clinicians have found it probably doesn't do that much, offer that much benefit, and so I think that its routine use has waned a bit. Ascorbic acid, also data not confirmed. We don't see this often used. And the last two agents, theophylline and phenoldiazepam, each are not used. They probably don't really offer any particular benefit. And there are actually risks associated with phenoldiazepam, particularly because it can cause hypotension, and the hypotension actually increases the risk for nephrotoxicity. So that's really not a reasonable option here. For cisplatin and carboplatin acute tubular necrosis, typically we talk about this also in the oncology support area quickly, but we're going to avoid other nephrotoxins. But we typically will give aggressive hydration, usually 1 to 4 liters of saline, often with mannitol. And there's also an agent, amifostine, which is a cisplatin chelating agent, is a potential agent to consider using in folks who are very high risk for nephrotoxicity, but who really would have benefit from their course of cisplatin. Amphotericin B, thankfully, we don't use much anymore. Generally, the pathogenesis is both in the proximal and distal tubule toxicity, and it typically presents even pretty early on in the course of a regimen of amphotericin B. Uniquely, what you'll see is in amphotericin B, acute tubular necrosis is actually a wasting of potassium. You'll see low levels of potassium associated with renal function. That's because the nature of the toxicity in the tubules, which is sort of unique for the way amphotericin does that, results in a lot of excretion of potassium and magnesium, and you need pretty aggressive management. Thankfully, though, you don't see this very often because this is an agent we no longer use very often. The risk factors for ATN with amphotericin listed here, and the prevention typically is if you can avoid amphotericin B, we do it in the first place, and if not, we make sure folks are well hydrated. Let's look a little bit now at the pre-renal toxicity and the hemodynamically mediated toxicity. And here, the issue typically is we want to make sure we maintain adequate head pressure in the glomerulus, what's circled. And so to do that, anything that decreases blood flow to the glomerulus in the first place, hypotensive episodes, septic shock, all predispose that to nephrotoxicity. In addition, we always worry about either excessive vasoconstriction or vasodilation in either the efferent or the afferent arterioles. And so we're going to look at, for example, with blood flow into the glomerulus, constriction, particularly somebody who has renal artery stenosis, is going to be a predisposition for hemodynamically mediated acute kidney injury. Add on top of that an ACE or an ARB, and lo and behold, you've got full-blown acute kidney injury, which is why ACEs and ARBs are contraindicated in patients with renal artery stenosis. In addition, if we have excessive vasodilation, that in the afferent and the efferent fiber, you're going to end up with lower head pressure in the glomerulus as well. So anything that affects head pressure just has to be just right, and anything that pre or post glomerular vascular changes can really be associated with a worsening in renal function. So let's look now at ACEs and ARBs, which are probably among the most common of agents that are associated with this hemodynamic-mediated acute kidney injury. And typically, you'll see a vasodilation of the efferent arteriole, a decrease in glomerular head pressure, and a decrease in GFR. And so this is an important concern for us for patients who have ACE or ARBs on board. We see a dose-related, sometimes dose-related effect. But typically when we start or increase the dose of an ARB, we actually may see the creatinine bump up a little bit. If it goes up really under 30%, serum creatinine rises less than 30%, and you're seeing the benefit in blood pressure control or heart failure symptoms, the reason why you're using the ACE or the ARB, then most clinicians will move forward making sure the patient remains adequately hydrated. Usually only when the serum creatinine bumps up above 30% higher than their baseline is when we start to back off on their ACE or their ARB therapy. Or if they're in a situation where we're aggressively diuresing them, maybe in the case of heart failure, maybe we do need to back off or hold the ACE or the ARB for a day or two until things sort of equilibrate. Risk factors for this, clearly renal artery stenosis, which is considered a contraindication for using an ACE or an ARB, or anything that affects poor blood flow, pre-existing kidney disease, or volume depletion, or concurrent NSAIDs are all risk factors. Now, you're going to have to weigh that out because an indication for an ACE or an ARB is heart failure, and it will improve morbidity and mortality in heart failure. So, and those patients are also going to likely be on a diuretic. So you have to moderate how you use diuretics and how you use the ACE or the ARBs. An easy thing usually, though, is just stop the nonsteroidals. If they don't need the nonsteroidal, really stop it. And if you have to use the nonsteroidal, let's say, for example, you've got someone in severe pain and you're trying to avoid opioids, and you've got a good reason to avoid opioids for whatever reason, then you need to make sure the patient is adequately hydrated. Way do we prevent this, typically with ACE and ARBs, is that we don't start the ACE and the ARB until the patient is really adequately hydrated, and we start at a low dose, gradually go up and watch their serum creatinine. We avoid nonsteroidals. You try to avoid excessive diuretics. That's not always possible. But typically, in hypertension, you're usually not going to see somebody start on a diuretic. You make sure they're adequately hydrated. You start them on a low dose of an ACE or ARB. Maybe we're looking at lisinopril, 2.5 or 5 milligrams. Usually 5 milligrams is what we see. And then you watch their blood pressure. You maybe bring them back for electrolyte panel with a creatinine in a few days or a week. Make sure they're doing okay. And if they are, then you titrate the ACE to your goal blood pressure in hypertension. In heart failure, typically what we're going to do is if you need to diurese the patient because they have pulmonary edema, then you may decide to not give the ACE or the ARB on day one. You may first let's diurese this patient, get some of this fluid off, get their fluid balance in a little better shape, then slowly start a low dose of the ACE or the ARB, carefully watching their kidney function and being careful about not over-diuresing someone while we're starting them on their ACE or their ARB. So here's a graphic that kind of will pictorially look at what's going on. When we have pressure in the afferent arteriole and it's constricted, that releases renin and angiotensin to cause vasoconstriction in the efferent arteriole, and that ultimately leads to increased glomerular pressure, and that you want to maintain that perfect head pressure. The problem with giving an ACE or an ARB is that that compensatory mechanism to maintain head pressure can be over-established or overdone. And so because the ACE or the ARB affects angiotensin II and therefore results in vasodilation in the efferent arteriole, what you then have is a decrease in glomerular pressure, and if that drops too low, hence you see the risk for acute kidney injury. And so we're careful about that. Maintaining that head pressure long term, particularly in a diabetic, is superb for reducing their risk for renal failure. So ACEs and ARBs are really ideal used to preserve renal function long term, as long as we keep that head pressure right where we want it. Nonsteroidals are also problematic for acute kidney injury. This happens a lot. We see this very often, particularly in an older patient who's been popping a nonsteroidal, or somebody who comes in, maybe often we'll see a younger patient who comes in with severe back pain and they've been popping naproxen or ibuprofen because of their severe pain, and lo and behold, they end up in acute kidney injury. The vasodilatory prostaglandins maintain that head pressure, and nonsteroidals really affect that. And so it can present often within days of starting therapy, and typically you're going to see classic drop in urine volumes, often and an increase in B1 and creatinine. And typically when you stop the nonsteroidal and make sure the patient's adequately hydrated, usually this is reversible, thankfully. But we really do like to avoid NSAIDs for folks who have any risk for kidney injury or other nephrotoxic agents on board. The risk factors for NSAID-induced injury are pre-existing renal function, folks who have lupus, if they have a high renin activity, particularly folks with heart failure or hepatic disease, if they're on concurrent diuretics or concurrent ACEs or ARBs, if they have atherosclerotic disease or they're older. And we typically would want to avoid the nonsteroidals in these patients. There is one nonsteroidal historically that's been on the market for a number of decades, Sulindac, that may affect kidney prostaglandin synthesis a little less than the others. Maybe it's a little safer. I rarely see anybody on Sulindac, and I think that this is a potential quote-unquote benefit of Sulindac that's probably not all that real. Keep in mind, though, that the COX-2 inhibitors, and we talk about these more when we get to the analgesic and pain group discussions, but the COX-2 inhibitors like celecoxib or Celebrex also have some of the same risks for renal failure as the other nonsteroidals do. So they're not really safer in regard to renal function. If an NSAID is used and then you see somebody going into kidney failure, the first thing to do is get rid of the NSAID. And usually in clinical practice, you can find another thing that's going to work in place of the NSAID to do what you wanted originally the NSAID to do. Let's talk a bit about cyclosporin and tacrolimus, hemodynamically mediated acute kidney injury. These are agents that are used primarily for transplant patients to suppress rejection. And most often that's the transplant that we see this used, probably most often because it's the most frequent transplant, is a kidney or renal transplant. The pathogenesis is related to vasoconstriction. It's probably dose-related, and it often will present with concurrent hyperkalemia, hypomagnesemia, and hypertension. Typically, this is all managed by the renal service and the transplant service. So folks who are on one of these cyclosporin or tacrolimus, particularly for transplant, would see this managed by that group. Now, we can also see cyclosporin and tacrolimus occasionally used for other conditions, autoimmune conditions and or situations where, for example, in severe psoriasis, or you sometimes see these used in rheumatoid conditions as well. And then you still watch for renal function because the same thing can happen there, but you want to talk to the specialist who's ordering or managing their cyclosporin. Consider getting cyclosporin levels to make sure they're in range and evaluate the risk-benefit of stopping therapy. So risk factors for this hemodynamically mediated injury with cyclosporin, for example, is increased age, high doses. If they've already had a kidney graft rejection, that's a problem. If they have hypotensive episodes, infection, or get a concurrent nephrotoxin. This is almost like a sort of many of these are the things you'd expect for any nephrotoxic issue. And we're going to monitor blood levels, serum levels of these agents to make sure they're in range. Uh, so basically, sometimes we see concurrent use of calcium channel blockers that may antagonize the vasoconstrictive effects of cyclosporin. Usually, though, that's going to be managed by the nephrology service. Typically, a general practitioner is probably not going to do that. Tubulointerstitial acute kidney injury involves the tubules or the surrounding interstitium around those tubules. Typically, it can have an acute or a chronic onset. The acute onset typically involves interstitial inflammation, infiltrates with a rapid drop in creatinine clearance. Typically, there's also concurrent symptoms of fever and a rash. The chronic onset is a slower process with usually the absence of any systemic symptoms. Most commonly, at least as I think of tubulointerstitial acute kidney injury, usually I think of an allergic-based interstitial nephritis, and typically the agents I think of are the beta-lactams. So sometimes the beta-lactams, occasionally nonsteroidals as well is seen here. And first of all, you'd be looking at a fractional excretion of sodium to determine that it is interstitial in nature, but you're also going to look at getting a kidney biopsy typically when you need to assess this. Chronic interstitial nephritis is often progressive and irreversible. The agent I think most often in this case is lithium. Long-term lithium use associated with this toxicity over usually many years. An acute kidney injury from lithium usually is an acute lithium high level, but this interstitial process is usually long-term, years and years of lithium. And the risk might be increased when we push the levels or give higher levels of lithium to maintain someone with mania or an indication of bipolar with an indication for lithium. Sometimes you'll see papillary necrosis. It might be associated with long-term use of analgesics. Typically, the older agent phenacetin, which is really no longer really on the market, at least in the United States, was the culprit here. I classically have not seen this as problematic in this day and age with acetaminophen, but at least in theory, it's a potential risk factor for folks who take long-term high-dose acetaminophen therapy. The post-renal or obstructive acute kidney injury, typically there's an obstruction of some point. There might be an intertubular precipitation. Maybe it's degradation products. We see this, for example, with rhabdomyolysis, with muscle breakdown. We see intertubular precipitation of myoglobin. You might see it with uric acid as part of a synopsis with elevated uric acid levels in tumor lysis syndrome post-chemotherapy for lymphomas, for example. Occasionally we see this with drug precipitation, particularly the older sulfonamides or methotrexate or very high-dose acyclovir or vitamin C therapy. But as long as folks are adequately hydrated and using normal typical doses, we don't usually see a crystal formation of a drug, but always something we think of. The way we prevent it is reasonable doses and avoiding precipitation by pre-treating or making sure the patient's well hydrated with a high urine volume. And depending on the agent that's involved, sometimes alkalinizing or changing the pH of the urine can result, depending on the nature of the crystal, can allow it to dissolve or be in solution. The extrarenal urinary tract obstruction, typically, most often we think of as benign prostatic hyperplasia or hypertrophy, or some other bladder obstruction. Nephrolithiasis usually doesn't affect GFR per se, but there are some drugs that predispose to kidney stones. A number of them listed here. Probably the two I think of most on this list are indinavir, which is an older agent used for HIV management, and topiramate, which actually as an anticonvulsant and has other indications for other neurologic and pain syndromes. Topiramate actually has a fairly high rate of developing crystals or stones. Typically, it could be in the range of 1 to 1.5% of patients. That's really a very high rate for a kidney stone. We also look at glomerular disease, proteinuria. Typically, we see this with patients with advanced diabetes. And so we look at microalbuminuria as a marker for early kidney disease in a patient with diabetes. But you could see a more dramatic proteinuria associated with a few drugs. Non-steroidals, we can see it. Sometimes you'll see it with heroin use. And in rheumatic disease management with parenteral goal therapy, which we don't use as much as we used to, we'd see this as an issue as well. With chronic kidney disease, the National Kidney Foundation looks at kidney damage for more than 3 months as a definition of chronic kidney disease, and then they have the stages that are listed in the lower half of this table. You could have kidney damage with a GFR that's 90 or more. That's considered stage 1. Stage 2 is GFR with 60 to 89, 3, 30 to 59, and so forth. So you can see those stages listed by the NKF. The etiology in chronic kidney disease, almost half is related, of new cases is related to diabetes management. Typically when you see patients in dialysis, usually half or so are, or at least half are patients with uncontrolled diabetes. Hypertension it contributes to this as well, another reason why we call hypertension the silent killer. And then glomerulonephritis makes up a lot of the difference, but then there's a host of other things listed here as well. Risk factors, typically higher risk factors in advanced age. We've talked through some of these issues, or if they have a family history, or sometimes it's even drug toxic related issues. It can there can be a precipitating factor initiation. Typically, the diabetes or the hypertension can be an issue, as well as drug toxicity. And the nature of how it progresses can be a function of glycemic control in a diabetic, chronic elevated blood pressure in a hypertensive patient, and whether or not they have pre-existing microalbuminuria that advances to more significant injury with higher levels of albumin in the urine, as well as smoking is a risk factor for this as well. So here are some tables that list at different ways that we stage chronic kidney disease. I encourage you to look at these. We've talked about these a bit. The lower half of the table, though, is the global outcomes, improving global outcomes categories for chronic kidney disease. And they use a similar mechanism with similar cutoffs, but a different numbering system. And so you might see either of these used when you're looking at a nephrologist, for example, staging a patient's degree of chronic kidney injury. Chronic kidney disease often will present with albumin in the urine or protein in the urine, and we really look at this as a marker for ongoing future risk, and particularly in diabetics, as we talked about in the diabetes section. So microalbuminuria is a absolute indication for considering ACE or ARB therapy early on to reduce the risk for this, or any diabetic even before they have microalbuminuria to reduce the risk for this developing. When we see a lot of albumin in the urine, folks are considered either macroalbuminuric with overt proteinuria, or when they have nephrotic syndrome, a high degree of albumin and protein in the urine. The Kindo categories for albuminuria also listed here. They mimic what we just sort of referred to. So when we assess kidney function, how do we do that? We're going to look at a number of markers. We're going to look at serum creatinine. The nephrology team may look at measuring the actual GFR with inulin, and that may require a 24-hour urine collection, which is difficult to do, surprisingly. And if folks eat a lot of meat or protein, or have a high muscle mass, or have an amputation, it's a little more difficult to sort of really do that accurately. We've already talked throughout the curriculum about estimating renal function which gives us a ballpark, but is influenced by a lot of factors, and so not precise, but helps us in ballpark adjusting doses for patients. When we have folks with diabetes, we always worry about nephropathy. Usually in these patients, it's a mix of their glycemic control plus hypertension, and so one of the issues, and as we've talked about in diabetes block, is to really manage their hypertension quite well. We typically look at managing, for anybody with diabetes, getting urine for microalbuminuria and the like, and monitoring that periodically. To slow the progression, typically we're going to look at patients with diabetes to get their blood pressure in good control. Typically, depending on the guidelines you look at, and the guidelines are always seeming to change or adjust. Maybe 4 or 5 years ago, it was pretty common to shoot for really low systolic pressures of 120 or 130. Then about 4 or 5 years ago, there was a debate about whether, hey, we could let them get a little higher. But now, as of late 2017, early 2018, we see that there is really a greater movement toward, again, lower blood pressures and maintaining pressures pretty low. We also look at ideally using an ACE or an ARB, even if the patient is not hypertensive, to really reduce the risk for microalbuminuria, and also important for us to get the best glycemic control we can do safely. Shoot for a glycosated hemoglobin less than 7%. For the subset of patients for whom they might get a high risk for hypoglycemia, maybe we have to live with a glycosated hemoglobin of less than 8%, but we really do the best we can. And in addition, we also look at reducing protein load or some degree of protein restriction. This gets harder, though, for a patient who's diabetic because, on one hand, we're telling them avoid a high-carb diet, and we want to keep an eye on their lipids and their fats, and now we're asking them not to eat a lot of protein. So moderation really is the key here, where you're looking at not excessive amounts of protein, maybe 50 grams a day or something in that range, to look at really shooting at vegetables, a lot of vegetable-rich diet, looking at some of the gooder fats or the better fats to use when they use fat in their diet, and using, when they use carbohydrates, to use more complicated carbohydrates with a lot of fiber in it. So all of those are, it's difficult, and you're probably going to look at a dietitian or nutritionist to be involved in the management of that and how we can kind of achieve that for many patients and yet make their life, livable and meaningful for them. For non-diabetic nephropathies, we're going to manage the hypertension, typically with an ACE or an ARB, but sometimes a diuretic, and minimize the protein in the diet. And then for all nephropathies, we're also going to look at stopping smoking and also managing the hyperlipidemia. Typically, we're going to do that also with a statin drug unless that's contraindicated. The goal blood pressures related to albumin levels, typically you'll see them listed here in the nephrology groups. I will say that if you look at the American Heart Association guidelines that were published in late 2017, they're looking at even lower levels than these. And so many clinicians now are even moving toward really a goal of less than 120/80 for patients with diabetes. So you'll see them, depending on which organization you're looking at, you'll see a variation in where those goals really are sitting. And then lipid management, almost everybody we're looking at, if they have chronic kidney disease, to look at a statin. Maybe the only exception would be folks who can't tolerate them, or maybe folks who are on dialysis already. But short of that, almost everybody else, we're going to look at starting them or maintaining them on a statin. For folks who are on dialysis or renal replacement therapy, the indications for that usually are when they have acidosis that's not responsive to usually oral sodium bicarbonate, electrolyte abnormalities. We can look at short-term dialysis for patients who have certain intoxications that are amenable short-term for 1 or 2 courses of dialysis to remove the toxin. But keep in mind there are many medicines that are not removed well by dialysis. Sometimes it's also used for fluid overload management in patients with symptomatic pulmonary edema when diuretics are not responsive. This is really in folks with renal insufficiency and fluid overload unresponsive to diuretics, or when they have uremia, specifically symptomatic uremia. And the most common modality that I think clinicians see is classic hemodialysis. They come to clinic 3 times a week for a 3 or 4 hour stint on the dialyzer. But peritoneal dialysis is the second mode. A third mode we're not going to talk too much about that is sometimes used in some healthcare settings is continuous venous hemodialysis, used in some intensive care units as a continuous low level of dialysis for their entire or for a longer period in their ICU stay. So hemodialysis involves getting access via a special fistula that the nephrologist will work with the vascular team on establishing. The dialysis membranes typically have a particular nature to them that will, in a sense, mimic the glomerulus and the glomerular filtration with a high flux and high efficiency with larger pores that can remove drugs that would be mimicking what's seen in the glomerulus. And then there are certain parameters that the dialysis team will calculate to look at the amount of clearance that a particular drug based on the time on dialysis and the volume of the fluid in the dialyzer and the amount of fluid that passes, the amount of blood that passes that filter as well. So there are certain formulas that they'll do, not critical for us as clinicians who don't work in nephrology or dialysis to really be fluent in those terms. There are complications in dialysis. One of the big things we worry about during dialysis, in the dialysis window of time, is severe fluid shifts and hypotension. They also will see not uncommonly cramps, nausea, vomiting, headache, chest pain. It's really pretty uncomfortable for a number of patients. And I will tell you that years ago when I used to round with a medical team, and on the medical teams we typically would round every morning at the same time patients would be starting dialysis. And it was not infrequent, maybe once every other month, we had a rapid response or a code response in the dialysis unit related to these fluid shifts that occurred that were pretty dramatic for patients when they undergo dialysis. So dialysis itself, with these fluid shifts, we really want to make sure that we're doing that in a way that is not overly aggressive for the patient and is done that is really carefully managed. We also see vascular access complications that can happen with catheters, and we always worry about either thrombus forming or an infection forming. For a thrombus, there are usual protocols that there is indwelling in that fistula between dialysis visits is a indwelling heparin. So there'll be a heparin, maybe 2 or 3 cc's of, sometimes it's as high as 5,000 units per ml heparin. That's all managed by the nephrology team, and it sits there. And then nobody is to touch that fistula. That fistula is only used for dialysis. Now imagine if a nurse went to administer a medicine via that fistula and they gave the drug, what they just also gave is the 10,000 units of heparin that are dwelling in that fistula. So what's typically done in dialysis is when the dialysis starts, the dialysis nurse or whoever's managing the dialysis will withdraw the fluid from that fistula with that heparin, discard that heparin, and then start the dialysis. And at the end of dialysis, after it's completed, to fill the fistula with heparin dwelling to sit in that area to prevent a thrombus. Occasionally, you'll see occasional orders for, and it's carefully done, for very low dose, low volume use of cath clearance with maybe thrombolytic like alteplase or TPA that's sometimes used for thrombus there. We're also worried with a fistula about line infection, particularly for Staph aureus and MRSA. And so always a consideration for anybody with an indwelling line or indwelling fistula. We worry particularly about gram-positive infections. The factors that affect the efficacy of the dialysis include the dialyzer that's used, the membrane that's used, the pore size of that membrane, the length of the therapy, the rate of the dialysis flow, the rate of the blood flow, the concentration of that dialysate, and how much it's going to pull off. So there are lots of variables that can be adjusted in dialysis with the fluid and rates that will augment how much fluid is the goal to pull off by adjusting the concentration of the dialysate. Also to look at the rate flow of the dialyzer solution or the blood flow. We alluded to some of these other modalities we have for managing dialysis in acute care and ICU care. We have continuous arteriovenous hemofiltration, continuous venous hemofiltration used when we primarily want to remove fluid in the ICU. There could also be a dialysate that's concurrent with that to remove more things when you need a better solute clearance. But those are specialized interventions that are done in only a subset of ICU settings, really. And I've not practiced in an area where I've had direct familiarity with these procedures, but in a more high-level tertiary care facility with an ICU, you may see these modalities used. Peritoneal dialysis is another form of dialysis, and this is really a patient preference about whether they want this or not. So the advantages of peritoneal dialysis is we use the existing peritoneum as the membrane, and these are usually done as cycled 4 or 5 solutions cycled during the night usually. So the patient will go to bed and will have a dialyzing peritoneal dialysis machine with maybe 5 different bags of 2-3 liters of dialysate solution, and for the first hour the peritoneum will fill with the first solution, and then that will drain after a couple hours, then the second, then the third, fourth, and fifth. And what they do is they slowly withdraw some of the toxins and manage fluid appropriately. The big issue with this, or the big complication with this therapy, is particularly if there's any potential contamination, is peritonitis. And so patient technique is critical, making sure the patient's aware of the risks and the benefits. But the advantage is that you don't have to go to dialysis clinic 3 times a week. And in many cases, it is a little more gentle in its pull-off of fluid. Peritoneal dialysis, typically there's continuous ambulatory. This is an older process that can be done during the day. But more commonly, we have these automated peritoneal dialysis that have really cycles at night. A patient goes to bed, they set up the machine, and it sort of automatically does things overnight, so they can lead a more normal life. You have to be really careful, though, about their ports keeping sterile, and it's a fair amount of management. It's still pretty intrusive for a patient. Let's talk about some of the complications with acute kidney injury with patients, particularly on dialysis. One of them is anemia. We expect to see anemia. This is usually a reduction in erythropoietin production in renal failure, and so many of these patients will require aggressive management of their anemia. They're also at higher risk for anemia because the lifespan of red cells is smaller, particularly if they're on dialysis. They lose some blood with each dialysis treatment. They may, over time, become iron deficient. They may, concurrent with their kidney disease and kidney-related anemia, also have anemia of chronic disease, and they often have renal osteodystrophy. So all of these are contributing factors for their anemia, and it's important for us to manage this. Now, the concern is that historically we used to be pretty aggressive in how we manage this anemia. In this day and age, the FDA has noted that we are less aggressive in managing it, with our goal hemoglobin hematocrit being lower than what they used to be. Historically, we used to look for a hemoglobin of greater than 13. We now definitely do not want that. We will look at their hemoglobin at typically being a much lower goal level, and once we hit 12 or 13, we're going to stop our intervention and our management for anemia and back off until it comes back down again. So the anemia workup typically for a patient who has chronic kidney disease, and usually the nephrologists are managing this, but you need to be aware of this, is that you're going to look for patients who have a serum creatinine less than 60 or a hemoglobin less than 11 You're going to get a hemoglobin hematocrit. You're going to look at their renal function over time. You're going to get a mean corpuscular volume, and that's for us to determine the degree to which, if they're smaller cells, are they iron deficient, and will they need iron studies. And then you're going to periodically look at their reticulocyte count to see how their therapy is responding. Are they making new red cells or not? You're going to get iron studies. You're going to look specifically at their transferrin saturation and their ferritin levels to measure how much stored iron there is. Because we could give them erythropoietin, but if they don't have enough iron as well, then all the erythropoietin in the world isn't going to do it because they don't have the raw ingredients to build new red cells. You're also going to look at a stool guaiac to see if there's any bleeding going on that could also account for anemia as well. So the use of erythropoiesis stimulating agents under the FDA, they have for a decade or so now been part of the REMS program. There's some debate about whether that's still part of the REMS program or not, but most clinicians still consider it appropriate to monitor using these agents for any use, but particularly in patients who have anemia. Typically, the goals now are to look at a goal hemoglobin level of probably around 11, but not to start, per the FDA in the last decade, not to start EPO until the hemoglobin falls below 10. The dose adjustments are based on hemoglobin response. We are a little less aggressive in our management, and we always worry also about hypertension as a function associated with too much EPO on board. If someone is failing EPO therapy, they're not responding in the way we would have thought, most often that's because they don't have enough iron on board. You want to also look at their iron stores and make sure they're getting iron replacement. And usually oral iron therapy does not work. Oral iron therapy is not aggressive enough. And so almost always with folks on dialysis, we're going to give them parenteral iron therapy. So here is a graphic of how we might look at the management of anemia of chronic kidney disease associated with renal failure, particularly in dialysis patients. So I encourage you to sort of look at this. Typically, we're going to see they're going to look at their usually starting them on EPO and iron, but you don't want to forget the other factors that are associated with anemias, including B12 and folic acid levels as well. And then if they're iron deficiency, add iron therapy, and with the goal of keeping their hemoglobin between usually 10 and 11. Iron therapy is almost always parenteral when we talk about folks in chronic kidney disease, usually dialysis patients. There are a number of different parenteral formulations available. Usually oral iron is not going to work all that well for someone in chronic kidney disease. Here's a graphic of some of the iron preparations that are on the market. I'm not going to go into depth with these, but encourage you to think about some of these are sensitizing, and so they particularly the older iron dextran is a fairly high rate for hypersensitivity reactions, and so in that case, we give a test dose. Most of the other products are not requiring a test dose, and the two agents that, at least in the practices I've been involved in over the last 2 or 3 years, have more commonly we see ferricet or ferric gluconate complex or iron sucrose venifer as the two agents, at least in the settings I've been in, seen those used as the more frequent agents in patients on dialysis. All right, let's talk about parathyroid status. Typically what you'll see in renal failure is hyperparathyroid. You'll see changes in calcium and phosphate management. So we will typically in these cases use vitamin D3, the active form of vitamin D. And keep in mind that vitamin D is activated in the kidney. So we need to give vitamin D3 supplementation usually to manage this hyperparathyroidism to affect or allow for remobilization of calcium into the bone. The signs and symptoms typically of osteodystrophy and hyperparathyroidism in a patient who is on dialysis or end-stage renal disease, they may have fatigue, they may have skeletal muscle or GI complaint, they may have variation in bone density and fractures if it's untreated. Here are some of the guidelines that are used for folks with more severe renal disease, how frequently to get calcium phosphate levels and parathyroid levels and corrected calcium and the like. So here you can sort of look at these as the frequency of monitoring for these folks. The non-drug therapy we're going to use for hyperparathyroidism is to look at the best we can to restrict dietary phosphate and phosphorus, and that is really hard to do. Phosphorus is in lots of products and lots of foods, and so doing a low-phos diet is very hard to do. It's not really practical to do. More commonly, we are going to use phosphate binders with meals to reduce phos in the gut. In the old days, we used aluminum-containing phosphate binders, but because of the risk for aluminum toxicity, aluminum is a great drug for binding phosphate in the gut, but unfortunately, the aluminum accumulates in renal failure, so we don't use that. Our first-line therapy for folks whose phos levels and calcium levels aren't too much out of whack is calcium-containing phosphate binders with meals. Most commonly, we'll see calcium acetate used, and it's appropriate to use as long as their phos levels aren't very high and their calcium levels aren't very high. So we're going to see these used. Typically, calcium acetate is going to be used with each meal to bind phosphate and reduce elevated levels of phos levels, and also maintain their calcium levels in a normal range. For folks, though, who have an elevated calcium phos product, if you take their calcium level times their phos level, and that's greater than 55, then you worry about calcium phosphate precipitation in tissues. And in those cases, we don't want to add more calcium to bind that phosphate because the added calcium increases the risk for that patient to develop calcium phos precipitation. In these cases, we're going to use one of these other two agents as a phosphate binder, also dosed with meals. Renal gel is probably the most common agent we'll see, although sometimes we'll see phosrenal used as well. And they're often the dosing regimen, particularly for the renal gel, is dependent on how high above their phos has gone, whether or not you need to go high or moderate or low dose. One other caveat or concern is the generic name of phosrenal, lanthanum carbonate, often could be confused with lithium carbonate, a very, very different drug. And so you want to keep your eyes open for avoiding this medical error that, at least in practice, I've seen happen a couple of times where someone picked the wrong drug. They picked lithium carbonate instead of lanthanum carbonate, very different drugs with lithium, and most patients with renal failure would be considered contraindicated or relatively contraindicated. So here's a table that includes some of the phosphate binders with some of the typical dosage and dosage forms that are used, and each of these are doses that are used with each meal. We also will look at vitamin D analogs. There are a number of them. They're listed here. They'll suppress parathyroid hormone synthesis and reduce parathyroid concentration, so they're routinely used. Most of these phosphate binders and parathyroid hormone management is usually done by the nephrology team. Typically, you as a primary care clinician or hospitalist probably are going to defer to the nephrology team for this. But if you see somebody who's admitted to the hospital and their phos levels are high, or you would probably want to talk with the renal team to confirm what they should be getting for phosphate binders and for vitamin D analog supplementation. Just keep in mind we need an active form of vitamin D for it to be effective, because the inactive, the standard older vitamin D formulation needs to be activated by a functioning kidney, and these folks don't have the ability to activate vitamin D. So here's a list of vitamin D serum levels with significant deficiency and some recommendations for dosing. We also may see for some subset of patients in chronic renal disease on dialysis, particularly where vitamin D analogs haven't really done what we need. They may add this cinacalcet to their regimen. And this can be used in addition to phosphate binders and vitamin D for patients who really aren't getting to our goal for phos and calcium balance. The issue to keep in mind, though, is that this agent inhibits cytochrome P450 2D6, and it's metabolized by cytochrome P453A, and so we just need to watch out for some drug interactions that could occur with this combination. Other things that you'll see in patients with on dialysis typically are a number of symptoms that we look at trying to manage and keep their lives more comfortable. One is restless leg syndrome. Restless leg syndrome is seen with a fair number of folks on dialysis, and typically we're going to use a dopamine agonist in some way, shape, or form. The two most common agents we'll see used are low dose of Sinemet, carbidopa, levodopa, or pergolide, or sometimes you'll see one of the other dopamine agonists used here as well. Usually, again, this is managed by the nephrology team. We'll talk more about these drugs in neurology when we talk about movement disorders and Parkinson's disease. For folks who don't respond to a dopamine agonist or you can't use a dopamine agonist, occasionally you'll see opioids or benzodiazepines, maybe one of the anticonvulsants or even clonidine used, but the efficacy for those modalities is a little less so, and so all those are really considered second line in restless leg syndrome. The other vitamin replacement, in addition to vitamin D, we look at water-soluble vitamins that are particularly removed from dialysis. So very common, we'll have a patient on dialysis on a water-soluble vitamin replacement. Typically, the brand we've seen for years is called NephroCaps, and there are a lot of B-C combinations with folic acid that are used specifically for nephrology patients. And so you'll find this is a common addition to their regimen. For patients who have significant orthostatic hypotension as a function of their dialysis particularly, you may find, particularly on dialysis days, that they are candidates for midodrine. And this is direct-acting alpha-1 adrenergic sympathomimetic causing vasoconstriction. It's not something that we use in every patient. We'd only use it for patients who are significantly orthostatic. And the first response before we go to this is to look at, are the dialysis settings done by the nephrology team, are they appropriate? Are we overly pulling too much fluid off of a patient, and that's why they're orthostatic? So, and there are a number of contraindications, as you could guess, for using an alpha-1 agonist, particularly folks who have existing coronary artery disease, if they have pheochromocytoma or thyrotoxicosis, anything where a sympathomimetic might be contraindicated. We also want to worry about tachycardias, or we want to look at anything else that's an adrenergic agonist might cause some issues with, so keep that in mind. You also want to be careful about giving other drugs that are affecting the autonomic nervous system. While you give these, maybe they may be counterintuitive or counteractive. Typically, when they're done, they're typically used on dialysis days. Sometimes we give a higher dose on dialysis days and lower dose on non-dialysis days. And that's all managed by the nephrology team again. We also spent a fair amount of time earlier in the year talking about drug dosing in renal disease, but let's kind of go back and look at this. The pharmacokinetic issues that are affected by renal disease, you'll see some differences in drug absorption, maybe particularly if a patient has nausea, vomiting, or changes in gastric pH, maybe, usually not big differences in absorption. You can see in renal failure some differences in drug distribution, particularly if there's a change in the water balance for that patient and it's a highly water or fat-soluble drug, then the volumes of distribution may change. So there are some drugs, for example, that the loading and maintenance doses are different in renal failure, not because they're renally cleared, but because how they're distributed. But again, that's a secondary issue in most drugs. Drug metabolism, usually not a big issue, but keep in mind that some enzymes, some of these cytochrome P450 enzymes are actually in the tubules. And so some patients may have some subtle differences. Very difficult to quantify that. Really the big difference, and as we'd expect, drug dosing in renal disease is decreased excretion for anything that's renally eliminated. And you want to think about certainly the drugs that themselves, the parent drug is eliminated renally, but you also want to think if there is an active metabolite or a metabolite of a drug that has some pharmacologic action or toxicity, we need to think about in patients with renal failure, they will accumulate that metabolite as well. So you want to look at your compendium for your references for different drugs to make sure for folks in renal failure that you're dosing those drugs appropriately. If you're working with a pharmacist or a pharmacy team, they will routinely look for that, but you could ask them as well, can you double check and make sure that everything looks right? So the class of drugs that we try dosing, these are some major ones, but there's lots more than these. So many of the antimicrobials, some of the newer anticoagulants particularly are renally adjusted. Cardiac meds are, some of the statins are, rosuvastatin particularly. The opioids can accumulate in renal failure. Some of the drugs we use in psychiatry and mental health, not too many, but a few of them have a renal clearance component to them. Many of the agents we use in glycemic control, particularly many of the newer agents are, and we usually titrate those based on blood sugar and hemoglobin A1C. But keep in mind, for someone with renal dysfunction, we need to adjust, particularly if it's acute, we may need to see some variation. We may see variation in that glycemic control and adjust their hypoglycemic agents appropriately. And then finally, at least listed on this table are some of the antiretrovirals as well. This is not a complete list. There are many other drugs that are renally cleared as well. So you want to look on a drug-by-drug basis whether or not the drug needs adjustment because of either the active drug or its metabolite clearance is affected by renal function. When we're giving drugs to patients on hemodialysis, we need to think both. Usually we'll dose the drug based on their renal function, but then they might need a supplemental dose after their dialysis. If the drug is not cleared between dialysis treatments, but is cleared to some degree after dialysis, then they might need their dosing immediately after dialysis. A classic example is vancomycin. Vancomycin, about 40% of vancomycin is cleared with each dialysis. Depends on the dialysis solution, the filter that's used. It's not always perfectly consistent at 40%. But typically what you're going to see is that between dialysis, you don't see much clearance of vancomycin at all for somebody with end-stage renal disease on dialysis. But then they go to dialysis, and at the end of dialysis, their levels go way down. So typically we'll look at dosing vancomycin post-dialysis. There's another issue, too, about when we get levels, and I'd encourage you to talk with a pharmacist about this. But typically, after dialysis is done, then the vancomycin or the drug levels typically are the lowest they're going to be, unless we've started to give them their antibiotic. But then that will re-equilibrate with the tissues, and the blood levels will go up because, keep in mind, what we're clearing during dialysis is the drug that's in the bloodstream. But we have a lot of drugs sitting out in tissues, and so what happens for the first couple of hours after dialysis, if you were to get a blood level right at the end of dialysis, the blood level or the serum level of the antibiotic or whatever drug we're looking at is going to be low. Then you don't give any more drug. You might find over the next 4 to 6 hours the levels go back up, and what's happening is the tissue drug is equilibrating back into the bloodstream. So you need to keep that in mind. Some of the factors, as we alluded to, that affect the drug removal and dialysis is molecular weight, water solubility, protein binding, the volume of distribution. And the dialysis itself, the type of dialyzer, the flow rates are all indicative of and duration of the dialysis treatment. All are factors that affect how much drug is removed with each dialysis treatment. All right, let's now talk quickly about immunosuppressants, and these are going to be used for folks who have renal transplant. And for folks who are transplant medicine, you want to just keep in mind that these are probably going to be managed carefully by the renal transplant service. But you just need to be aware of it, and where are some things when you need to call a transplant service to say, hey, we need to look at adjusting this. Typically, when someone's on a transplant, has an organ transplant, and kidney is the most common, liver and heart probably the next two more common organs for transplant. These folks need immunosuppressants so they don't reject their new organ. We typically will look at giving a group of potent anti-rejection medicines at the time of transplant. These are usually called an induction regimen, and then transferring them to a maintenance regimen to prevent rejection long term. There's generally four sort of classes or groups of drugs that are listed here for maintenance therapy. I encourage you to quickly look through some of these and at least have some name recognition and familiarity. The other issue with these immunosuppressants you always want to think about is when we're suppressing the immune system, that's a good thing for somebody who has an organ transplant so they don't reject their organ, but it's also a dangerous thing from the point of view of infection control. And maybe the suppression of immunity might also slightly increase their risk for certain types of cancers because the immune system is also periodically scanning the body for things that are foreign, including early cancer cells, and trying to reduce the risk for those as well. So when folks are on one of these therapies, we're typically looking at monitoring their renal function over time. Their transplant service will look at that carefully, monitoring for infections of any kind. You clearly want to be aware of that, and to look for any adverse effects, particularly signs of infection, upset, or change in renal function. And then also look at drug interactions. Many of these agents, particularly cyclosporin, is notoriously involved in many of the cytochrome P450 enzyme interactions. So we need to be aware and very careful about that. So here's some lists of some of the drugs we use in transplant medicine, some for induction and some for maintenance. Typically, the maintenance therapies we'll see patients on most often are the top three, or actually all of them we'll see, tacrolimus, cyclosporin, mycophenolate. We also see sirolimus not infrequently. Azathioprine is an older agent which we occasionally see patients on. I don't see patients on that as often as some of the others. Here's a list of some pharmacology for some of these more specific agents. I'm not going to spend a lot of time on this. Just scan through them and just be aware of this. Simulec, for example, used for initial therapy is a monoclonal antibody to help prevent rejection. Zenipax, also monoclonal antibody used initially around the time of transplant. Also OKT3, another monoclonal antibody, pretty aggressive therapy just around the time of transplant. And thymoglobulin, a polyclonal antibody, also used typically just around the time for transplant. The other agents that you'll see used, and many of these remaining agents listed here in the transplant service are more commonly seen longer term for patients. Tacrolimus is one of them, might be more effective than cyclosporin for preventing rejection, but may be a little more adverse effects associated with it, but also carefully managed by the transplant services. The pharmacokinetics of tacrolimus are here. Nephrotoxicity is a concern for us, so we're careful about how we monitor patients on this, and there are a lot of drug interactions and food interactions that need to be carefully monitored with tacrolimus, as we do with cyclosporin. Cyclosporin is sort of an older agent that still sort of is considered the mainstay of therapy for many patients who have an organ transplant. We also use cyclosporin for other autoimmune conditions as well, not just transplant patients. So you'll see it used for other purposes, particularly advanced derm cases or rheumatologic cases. It's reasonably absorbed orally, lots and lots of drug interactions with cyclosporin though. So the other adverse effects with cyclosporin, nephrotoxicity, so we need to be careful about that. Always worried about infection risks for folks on any of these immunosuppressant agents. Cyclosporin has a low but real risk for hepatotoxicity, and as we alluded to, any of the immunosuppressants, you think about lymphoma risk, not huge, but because we're suppressing immunity, we're increasing risk for things like lymphomas. Other adverse effects listed here. Anaphylactic reactions, pretty rare, but they can happen. We are cautious and try not to use these agents in pregnancy. There are lots of interactions with cyclosporin. We basically list a number of them here, but because they affect cytochrome P450, we see these used really monitored carefully whenever we add or subtract a drug from the regimen for somebody who's on cyclosporin or tacrolimus. There are different preparations that are listed here. And then mycophenolate, like cyclosporin, works to affect immunity, typically through T and B lymphocyte production. And some of the things we think of with mycophenolate, like we think of with tacrolimus or with cyclosporin, is the immune compromised nature of patients who are on these drugs. Azathioprine, less commonly used, but can be seen occasionally, listed here. And sirolimus, sometimes we see this added to the regimen or part of the regimen. Again, some of the same types of drug interactions with the cytochrome P450 enzyme systems as well, so we're careful about that. Okay, so we've covered a fair amount of content here of all the drugs we expect you to recognize dose, probably calcium carbonate.